and welcome to the final webinar of the year with the Outside Clinic. Just a bit of housekeeping before we start off. So this should be a 1 hour webinar with a Q&A at the end. So Liam's happy to take any questions towards the end of the webinar. One CPD point for tonight, and the CPD certificates will be with you within 7 days of today. So I'm delighted to welcome Liam Kite of Anglia Ruskin University. 30 years of experience within the dispensing arena, and I think I'm right in saying a previous winner of the Association of Optometrists Lecturer of the Year. So without further ado, I shall hand you over to Liam and look forward to enjoying the content on this rather chilly Thursday evening. Over to you.
Thank you, David. Hello, everybody. Very pleased to be here. Although I have to say, as I've been watching the names come up on the screen as people joined, I got the shock of my life because one of the people within the room today has got exactly the same name as my old headmaster. And I spent many hours in his office explaining why I'd been naughty. So just for a second, I had a little panic attack. So what I'm just going to start by doing is sharing my screen with you. And what we're going to do is have a look at several different little bits and pieces, little tips on how we can do the measurements. Now, as we've gone through some of the seminars that we've done during the year, one or two people have said things like, well, it's been 30 years since I last did dispensing, and it's a little bit difficult to remember back to best practice. So David and I decided that a webinar would be a good idea just to remind ourselves of some of the measurements and some of the techniques to take these measurements, but particularly trying to relate them to the domiciliary patient. I can't see the chat while I'm in presenter mode, but if you've got any questions as I go through, if you pop them in the chat at the end of the slides, what I'll do is I'll open up the chat and then I'll be able to answer the questions as I go along then. So what we're going to cover today is dispensing measurement techniques for home visits and measurement techniques for the freeform lenses that we have discussed in previous sessions. So the following learning outcomes will be covered: keeping knowledge and skills up to date, S5 in clinical practice, and a little bit about communicating effectively with patients. That's mainly going to be around directing the patients into what you want them to do so that we can then take the measurements. It's something that I find a lot of the students these days are a little bit reluctant to do. Things like, now look to your left, now look to your right. And we do that when we're doing the actual eye examination, and we sometimes forget to do that whilst doing the dispensing itself. So we're going to look at clinical practice and communication, and this will be embedded as we go through. So I've put some little questions up, and these are questions that I get asked quite a lot. And so I'm put these questions out there. I'm not expecting people to start shouting out answers or anything like that. I'll answer them. But these are questions that come up almost as frequently asked questions. So which of the following measurements is not affected by the patient's posture? So the bifocal height, the near centration position, head width, and the fitting cross position for things like occupational lenses and progressive powered lenses. Now, the only one that's not affected by posture is head width. Now, if the patient is confined to a wheelchair, then the bifocal height, the near centration position and fitting cross will all be different to how they would be if the patient was fully mobile. and how they would be if the patient was in a more comfortable chair or a sofa. So what we need to do when we're doing these measurements is observe the patient, and this is where the communication comes in. We need to ask the patient, when I'm not here doing the test and doing the dispensing, where would you normally sit? How would you normally sit? And if possible, whilst you're doing the domiciliary, get the patient to be in the chair or sofa or position that they would normally be in if they were going about their normal day-to-day activities. So a couple of reminders. Which measurements do we need for a general dispensing? Well, of course, we need the optical centers or the patient's PDs. I normally only take the monos these days because I find that more accurate. But whether you take the monos or the full PD, that is fine. We need the heights mainly for things like bifocals, PPLs, or if we're doing a freeform lens or an aspheric lens, we will need to take the heights. And this is where we also need to observe what the patient has already got. So if they're wearing the bifocal slightly higher than you would normally fit it, then we need to match that. If we've got a situation where the patient is having a frame that's fitted quite at quite a pantoscopic tilt, we need to take that into account, ready for the heights. And if they're wearing aspherical lenses, were they ordered with heights before? If so, keep it that way. But if they weren't dispensed with heights previously, we have to take that clinical decision. Do we want to put the heights in? If we do put the heights in at that point, we then need to sit back and say to the patient, okay, we're going to make these up slightly different to how you had them last time. So when you get the new specs, they may be a day or two just adapting to them. Of course, if the patient does have mobility issues, we need to be very careful that we match heights from previously. And I'm afraid I'm of the opinion, if it's not broken, don't try and mend it. We need the Vertex Distance. We all know that this should be on there. Excuse me, this should be on there when the prescription is over ±5 diopters in the strongest meridian. But again, if we're doing some sort of freeform design, some tailor-made lenses, then the Vertex Distance will be needed. Eye size and distance between lenses. We need that for two reasons. The first reason, obviously, is to make sure the frame's going to fit the patient. And the second reason, if we are doing a more complex lens, again, like a PPL or an occupational or a freeform tailor-made lens, this is needed so that we can guarantee that we've got the effectivity constant, irrespective of the line of sight or the line of gaze. I always like to take side length. The reason I like to take side length is I then know that the frame is going to be fitting as accurately as possible once we've set it up before we then put it onto the patient's face. And I like to take head width for exactly the same reason. If I know what the head width and the slide length is before the specs get delivered, I can set the frame up to those measurements, and there's less adjustments required on the collection. I spoke to a fairly large company not long back, and they said, oh, we don't need to do the side length and the head width. And I said, why not? And he said, oh, it takes a little bit too long. I said, yeah, but you've then got to start doing all the adjustments when the patients are there. And if you can take the side length and the head width and get the frame set up to that, when you put it onto the patient, it feels as though it belongs to them. And that will give us a real benefit because the patient will have more confidence in what we're doing. It's a little bit like when you go and collect your new car. They don't say, do you want 4 wheels on it? The wheels are already there. And if we've got the frame set up to the correct fitting prior to putting it on the patient, as I say, it gives that professional appearance and there's less adjustments required in front of the patient. So which measurements do we then need for freeform lenses? Well, these are very much the same as the previous slide. And this time, as I mentioned on the previous slide, we do need the vertex distance irrespective of the prescription. We now need the vertical eye size, whereas normally we just talk about the horizontal. We need the face form angle. And what we're going to do with the face form angle is we're going to fit the frame and then measure the angle. And we need the pantoscopic angle or the pantoscopic tilt, depending on what term you're used to using. So we need these little extra ones in order to make sure that we have got a freeform, a tailor-made lens for the patient. So the optical centers, and please, 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 I'm not trying to say that we need to be taught how to take the optical centers. What I'm trying to do here is do this as a reminder and just make it relevant to a patient in a home environment. So monos or PD, I prefer the monos. If you prefer the PD, that's absolutely not an issue as far as I'm concerned, but we do need to take into account the patient's posture. So the first thing not to say is sit how you normally would do, because the minute you say to a patient, sit how you normally would do, they don't know how they normally would. And they start either trying to sit up or sit forward or lean into you. And that's going to give us an incorrect measurement. So what I normally just say to the patient, again, particularly in a domiciliary setting, is I will say to the patient, OK, I'm now just going to take a couple of measurements. You stay where you are. I'm going to do the moving around. And that way the patient will relax a little bit and be in the position that you need them to be in. It's always also worth noting when you enter the room, how is the patient? Are they an upright patient? Are they a slouchy patient? And if they're upright, you're going to take the measurements upright. If they're slouching, you're going to take the measurements slouching. Now, what we need to try and do is avoid parallax. And so we make sure that we're at an eye level with the patient, square to the patient wherever possible. Now, I appreciate that some of our patients might be in a bed, might be in a wheelchair where it's a little bit more difficult to get square to them. But whilever you can, get square to the patient, and always try and take the monos at arm's length. The reason we do that at arm's length is to try and reduce some of the accommodation when the patient is trying to look at you. And also, if you're an older practitioner like me, I don't have to accommodate as much at arm's length as I do when I get a little bit closer to the patient. So on the next slide, what we do here is we have a look at my very, very good colleague, Gwendolyn. Gwendolyn here is sitting very upright, as we can probably see from the picture. And my colleague taking the measurements, Kat, what she is doing is she's just resting the ruler onto the bridge of the nose and pressing, not hard, but a tiny bit of pressure onto the forehead to keep the ruler steady. Kat's also got a couple of fingers on the side of the head, which again just helps to steady the ruler, and it stops any shake we might get. Now, obviously, I couldn't be directly in front of Gwendolyn because Kat's head would have been in the way of the photograph. But what we've got here is the patient looking at the open eye of the practitioner to line up the 0 of the ruler on the outer pupil edge. And we measured from outer pupil to inner pupil edge. And then we repeated that from inner to outer. So we took the measurement twice, outer to inner and then inner to outer of the pupil edge. Now, Gwendolyn's iris is nice and dark brown. And if we'd have struggled to see the pupil edge, what we could have done is used a pen torch. And from the side, left-hand side, as we're looking, we could have shone the pen torch into the eye, and that would have made the retinal reflex red, and it would have given us a clear demarcation of where the pupil edge is. So again, get your patient to sit how they normally would. And I said to Gwendolyn, I want you to imagine that you're in a wheelchair and therefore you're restricted, you can't lean back. And so she sat quite upright with her chin quite raised, because that is how she perceived she would sit. So observing the patient will help us make this measurement. And just these little tips: make sure you're at arm's length, make sure you've steadied the ruler, and we will get the most accurate PD that we can. We've come from the opposite side here to demonstrate that we're now remeasuring this from the inner to outer edges of the pupil. And again, from this angle, we can see a little bit more clearly that Kat is just resting the fingers gently at the side of the head, so that the patient can't shake and the ruler can't shake, so that we've got a stable reading there. So heights. Now heights could be bifocal heights, could be optical center heights, could be fitting cross heights. And again, we should fit the frame first. And I always try and get the patient to put the frame on, because the patient knows where they wear the frame. And by letting the patient put the frame on, it's going to go on to the same place each and every time. And that means we're going to have consistent measurements. Now we can do all sorts of things for this. Now, when I first started, we used rulers. And then I'd been working for the company for about 10 years, and they brought in the little spring-in focal gauges that clip into the top and bottom of the rim. And it's a ruler scale, and it meant I didn't have to put my ruler on. And then a couple of years ago, I discovered these little reusable stick-on templates from a company called Louis Stone. Now, I'm sure other companies do these, and I am aware that for CPD, I shouldn't really be naming companies, but Louis Stone has these little stick-ons. You put them on the dummy lens, and it is a ruler, just a series of 2mm gaps going from the bottom of the frame upwards. I find those quite useful. Excuse me. I find those quite useful, particularly if we've got a patient who may have a slight tremor, may have Parkinson's, for example. And by using the little stick-on templates, I'm not trying to steady a ruler against the head, and it is quite a useful thing to do. Quite a lot of people will actually use a marker pen, a Sharpie, and try and mark on the lens where the pupil center is. Personally, I'm not a fan of that, because as somebody comes towards me with a pen, I'm going to move backwards wherever I can. And also sometimes, again, if you've got a patient with a head tremor, you might find that the dot is not a clear, concise dot, but there's lots of little waves on a line, which when you then take the frame off, you know, do I go to the top? Do I go to the bottom? Do I go to the middle? However, what I do once I've checked the heights, I will take the frame off the patient. I will mark on the position that I've measured, and then put the frame, or well, let the patient put the frame back on, so I can see that the dot is where I thought it would be. And again, if you've got somebody that is sat in a wheelchair or sat in a high back chair, you are going to find that this is going to be a little bit higher than you would normally expect. So what we've got here is the frame on the patient, and we are resting the ruler onto the front of the frame. And this is being measured for a PPL. And so we're looking for the pupil center. And what we are doing, we're measuring from the lower tangent to the frame, and we're at the inside of the frame rather, and we're measuring up to the pupil center. We've got the ruler pressed against the frame, and again you can see that Kat has got a couple of fingers resting onto the side of the head. In the event that we've got a patient with Parkinson's or a head shake or a head tremor, then this will help steady everything with the patient. Now, we're showing this being taken on the patient's left eye. We would repeat this on the right eye. And again, just to reiterate, once I've taken these measurements, I would make a dot on the dummy lens and just have a look and make sure it is where I thought it was going to be. I've taken the dummy lenses out of this frame so that we didn't get a reflection from the dummy lens when we took the photograph. Now, if we're pedantic, British standards say that we should take the fitting cross from the horizontal center line. I'm not a fan of that myself because that involves a calculation. I've then got to measure the depth of the frame, halve it, and then I've got to remove that from the measurement that I've just taken. And the vast majority of lens manufacturers are quite happy if we say we want the fitting cross, as this one is, 28 millimeters above lower rim. And they're quite happy to work with that, and we will get a lovely accurate measurement doing so. The vertex distance. So again, this is a reminder. Again, we should fit the frame first, adjust it, make sure it's as it should be, and then we should allow the patient to put on the frame. Just repeating myself, this means that that frame is then always going to be in the same position. And we can use a ruler or we can use a Vertex Gauge caliper. Now, for the ruler, all I do is I get to the side of the patient and I get the patient to blink a couple of times, and that is then going to give me an idea of where the corneal apex is. And I measure from the back plane of the frame to the corneal apex and rest the ruler on the side. One of the advantages of home visits is we tend not to carry a phoropter head around with us. It's much more likely going to be a trial frame and a set of trial lenses. And on the vast majority of trial frames, you can measure or read, should I say, read on the side what the vertex distance is, because as you fit the trial frame, you'll obviously fit it at a correct vertex distance, and we can measure that. Or you can use a Vertex Gauge caliper. And that is what a Vertex Gauge caliper looks like. I've got this set up for the right eye. Now there are two, it opens like a pair of scissors, and there are two little prongs on the right hand side as you see it. One's got a little bump on it. Now that little bump goes on the back of the dummy lens. You obviously take this with the patient's eye closed, and what you do is you put it in between the frame and the patient's eye and slowly open it out until it just touches the outside of the eyelid. This is showing as being for the right eye. You would then turn it round for the left eye, and you would measure each individually. Now you can see on there the scale of 10, 15, 20, 25. I would suggest that if we've got a 25 millimeter vertex distance, we would need to just recap because that's a little bit large. As we know, generally speaking, vertex distances are going to be somewhere between 8 and 12 mil. And the vast majority of practitioners seem to like to land on about 10 mil as being a good distance. This is one that takes a little bit of patience to do, and when I'm teaching this to the students, I get them to practice on each other, and I say to them, look, you've got to be gentle with this, because if you hurt the person, they're then going to take the measurement on you and they're going to hurt your bike. But what we need to do with this is just take our time, practice a few times on willing volunteers. I tend to find this time of year when the carol singers come round, I say to them, yes, of course you can sing me a carol. I'm just going to measure your vertex distance while you do. And you know, when you've got wives and girlfriends and boyfriends and husbands, or any combination of, practice on those before you practice on patients. So we need vertex distances to calculate effectivity at the cornea. So if we've got a +6 prescription at a vertex distance of 10 mil, what will the effect at the cornea be? Now, when I teach this again to the little students, if I give them a question like that, they get a little bit confused. So if I then say to them, the spectacles are +6, what am I going to order for a contact lens? Then it starts to become a little bit easier for them to see. So it's not going to be a +6 because that's the spectacles. So it's either going to be a 638 or a 566. And in fact, for a positive lens, the corneal prescription or the contact lens power will always be more positive than the spectacle. So it's going to be +6.38. D's there, insufficient data to calculate because I couldn't think of a fourth option that looked reasonable. So eye size and distance between lenses. So this is a measurement of the A measurement, as it's often called in practice these days, not a measurement, but the A measurement, or the horizontal boxed lens size. It's the maximum horizontal size of the lens. The B measurement, or the vertical box lens size, again, is the maximum vertical size of the lens. And the DBL, distance between lenses, is the minimum separation of the right and the left lens. Of all the measurements that we're doing today, this is the one where we don't need a patient. And what we do is we have a look at the frame. And as we look at the right-hand side, there is a vertical line, and we put the furthest edge of the nasal edge of the lens onto that line. And then as you look at the left, you'll see inside the lens, you'll see 38 and 42. Then outside the lens, you'll see 46, 50, 52 and 56. And what we're looking for is the maximum width from the nasal to the temple edge. And what we can see on this one is we can plainly see the 42 line. We can't quite see the 44 line. But there we've now got a dotted line showing where the nasal edge is and a dotted line showing where the temple edge is. And the distance between those is going to be 44 millimeters because it lines up at the top of the picture with the 44 line. 42 is obviously too small, 46 too big. So a reasonable answer to that is going to be the 44. So that is the horizontal calculation there. What we would then do is just rotate the frame, leave the ruler where it is, rotate the frame by 90 degrees. And then you can see the 38, the 40, the 42, that would then come into play. If it's a little bit less than that, then we can use the other side of the ruler that has got 36, 34 and 32 on there as well. To do the distance between lenses, we put the one side of the frame on the vertical and then we measure to the other side of the frame. And this is the minimum separation of the two lenses. And on this one, this is 22 millimeters. So when we order this frame, we would order it as a 44 by 22. And that will help make sure that we've got the perfect fitting frame for the patient. So for the best cosmetic appearance, the box center distance of a frame should be as close to the patient's PD as possible. So the box center distance is the horizontal lens size added to the distance between lenses. And in this case, the lens size is 50 by 40 and the DBL is 22. So we add together the 50 and the 22. and that gives us a box center distance of 72 millimeters. So if the patient's right mono PD is 33, what is the decentration? Option A is 3 millimeters in, option B is 3 millimeters out, and C, we need to know the full PD first, or the lab will work this out for us. Well, D, the lab will always work this out for us, but it's useful for us to know. Now, if we've got an aspheric lens, if we've got huge amounts of decentration, we're going to see some of the asphericity at the edge of the lens, which can then cause small disturbances in the vision for the patient. What we'd like to do is try and keep the decentration as small as possible. In an ideal world, in a perfect world, that's going to be 0. But if you've got a patient like mine, my PD is 59 and my head width is 150 mil. So my PD is relatively small for the side of my head. So I'm going to end up with decentration. But if we try and keep the decentration to less than 5 mil, we're going to have a good fitting frame. And we're going to have the lenses behaving as they should do. Should we have it as in or out? Well, this is a personal preference. I don't like to see the eyes in the outer half of the frame, because to me that always looks as though the frame is too small. So in an ideal world, we would like the decentration to be inwards. So let's just have a look at what we've got here. As we said, 50 added to the 22 is 72. What we do to find out the decentration is we halve that 72. That's going to give me 36. 36 minus the mono is going to give me 3 millimeters. So I know that the decentration is 3 mil, but is it 3 mil in or 3 mil out? Little trick that we teach to the students. If you do the box center distance divided by 2 minus the mono, if it's positive, your decentration is in. If it's negative, your decentration is out. So 50 plus 22, 72, half of 72 is 36. 36 minus the 33 is 3 millimeters, and therefore it is going to be plus 3 mil. That's 3 mil inwards. So the face form angle. This is usually going to be between 5 and 10 degrees, with the most frequent one that we see in practice round about the 7-degree mark. Now, if you are ordering lenses that are designed to be freeform, so that we've got the same effectivity irrespective of the line of gaze, if you do not specify the face form angle, the manufacturers will revert to the default, and the default is 7 degrees. So we really should be measuring it, because just a 1 degree difference, let's say it's 6 degrees, that's only 1 degree difference. But when you then move outwards towards the temple edges of the lenses, that 1 degree is going to be a significant amount. Now, the way I do this is I do not try and measure it on the patient, even if I'm in a situation where I'm in the clinic and we've got young, active patients. I don't measure it on the patient, because it's very difficult to do, and you've got to be in exactly the right position. So what I do is I fit the frame, then I let the patient put the frame on so I can recheck the frame. And what I do is I get the patient, as much as they possibly can, to drop the chin. So I'm looking from the top, and I look to make sure this curve, the bow angle or the wrap angle we often refer to it as, I look to make sure it's fairly constant as we move from the nasal edge out to the temple edge. Then what I do is I actually measure the frame. Okay, now there's lots and lots of tools to measure this. I borrowed this tool on permanent loan from Essilor, and what we can see here is that the curve of the frame will line up with one set of angles. Now it's measured in 2, 4, 6, 8 and 10. And on that one, it is somewhere round about the 4 degrees. Okay, so this one is a little bit flatter than we would normally be happy supplying, but it's just there to demonstrate that angle. Now, this particular tool, as I say, this one I acquired from Essilor. They call it their dihedral angle rule. The dihedral angle rule. The word dihedral, I've got to be honest, is one that's made up. It's not a British standard or European norm term. It's not even an ISO term. The ISO, EN and BS all have this called the face form angle. In practice, we'll often refer to it, as I said a moment ago, as the wrap angle or the bow angle. I don't really mind what we call it, so long as we measure it, because we need that to be accurate so that when the patient looks left and right, we've got a consistent effectivity. So by having the wrong face form angle, how is the prescription +7 likely to be affected? And what we're going to do is we're going to assume that the angle is supplied at 10 degrees instead of 5 degrees. So what's it going to do? Is it going to give me an increase in sphere power and an induced SIL axis vertically, or the same but axis horizontal, or decrease in sphere power and a positive SIL vertically, or a decrease in sphere power and an induced positive SIL horizontally? Well, the face form angle is a vertical angle. It's a vertical rotation. And when we rotate vertically, we will have a vertical axis. So A and C are the only options we have now, because it will be a vertical SIL that is produced. It's a positive prescription, so it's going to be a positive SIL. And in twisting the lens, we make the ray of light go through the lens obliquely instead of perpendicularly. And that will increase the sphere power. So if we've got a +7 and we have it angled too much, then that is going to increase the prescription. If anybody's interested in the maths behind it, I'm happy to talk through the maths behind it outside this venue, but it will end up with a +7.07 with a +0.3 SIL axis 90. So by getting the wrong face form angle, we're actually going to induce a SIL that is not in the prescription. And lots of people tell me that patients really can't tell if there's an 0.25 SIL in there or not. However, it's outside the tolerances, and therefore we need to make sure that we're getting this angle correct. Pantoscopic angle. Again, we're just going to think about this, that this is normally going to be between 5 and 15 degrees and often around the 10-degree mark. And again, if you don't specify this, the default will be put in as 10. Now that default is used by Zeiss, Essilor, Hoyer, Rodenstock, Seiko, and even good old Norval will use that as the default. So we need to measure this. And what is this measurement? Well, this, if we can imagine the imaginary line between the brow and the jaw, what we're looking is the difference between that line and the vertical. Now, this particular measurement often gets confused with angle of side. Now, angle of side is how much the side drops down from the horizontal, whereas pantoscopic angle is how much away from the vertical that line between the brow bone and the jawbone is. Now, again, we can do this two ways. We can either fit the frame and measure the frame, especially if the patient has mobility or posture issues, or we can actually measure the method shown on the next slide. Now, when we pull on this, what we can see here is a facial gauge. This shows how old mine is, because mine was made by a company called Reese, who haven't been making these for at least the last 10 years. But these facial gauges, the best place to get these is actually on eBay, where they go for about £3.50 a throw. And what we do is we line up the vertical on the patient. We line up that vertical cursor on the patient, looking from the brow to the jaw. Now, my patient here, Gwendolyn, has got some Chinese ancestors, and so her face is quite flat. Now, if we've got somebody that is from the Far East or maybe Afro-Caribbean, we're often going to find that this pantoscopic angle is smaller than the Caucasian face. So we might find this somewhere between 0 and 5, whereas for, as I was saying on the previous slide, for the Caucasian, we're going to find this somewhere between 5 and 15, more likely around about the 10 degrees. And all we do is we measure on the inside of the little cursor at the top onto the degree scale there. Unfortunately, Kat has got her finger in the way, so we can't see exactly what that measurement is. One of the things that we are producing at the university at the moment for student use is a video of all these measurements being taken. And once I've produced this video, if anybody would like a copy of it, you are more than welcome to have that with my compliments. So in the event that the pantoscopic till is incorrect for a varifocal dispensing, 0 degrees instead of 10 degrees, what will be the effect for the patient? So I'm going to work from the bottom up. The frame will be uncomfortable. Well, it might make the frame uncomfortable, but it's likely to have more of an optical effect. The patient will need to drop their heads to see into the distance. Well, that won't happen, because if we've flattened the pantoscopic tilt, making it 0 instead of 10, the fitting cross is going to only have moved by about 1 millimeter at most, and it will effectively not affect, that's really bad grammar, Liam. It won't have an adverse effect on the vision. The patient will need to lower the eyes more to read. Well, as I pull the bottom of the frame away, the eyes will need to lower less in order to read. The corridor and the near zone will be reduced in width, and this is the actual answer for this. So as I pull the frame out, the actual frame fitting will be uncomfortable slightly, but the optic effect will be that we've more or less got no corridor and only a little bit of near. Now, when we use a scanning phasimeter, that shows us where the aberrational astigmatism, or the distortion as we call it in practice, is on a frame. And we see those little isocylinder lines, and we know where the corridor is and how wide it is, etc. But if I then flatten it on the scanning phasimeter, then you see that those isocylinder lines get closer and closer and closer together until they almost meet. Richard Edwards from OCCS and I were having a discussion earlier on in the year, and he was telling me that a lot of people that complain to OCCS about their progressive lenses, it's due to the fact that the pantoscopic tilt is incorrect, and we've therefore lost the intermediate zone. So this one irrespective of whether you're dispensing in practice or dispensing in a patient's home, we need to make sure we're doing this one particularly for varifocal dispensings. Question number 6, with respect to freeform lenses, if we do not take all the measurements and use the defaults, which statement is correct? It will be made using freeform technology, but will not be a true freeform lens. It will not make any difference unless it's a high-powered lens. The patient will reject the lenses. The patient will complain. From experience, I find that it will be a lens made with freeform technology, but will not be a true freeform lens. What will happen, it will be a reasonable quality lens and it will be usable, but it won't have all the benefits of freeform lenses. It will not make any difference unless it's a high-powered lens is an interesting one, because it's more to do with what the visual acuity of the patient is, what the contrast sensitivity of the patient is, as opposed to the power of the lenses. So if you've got a patient with lower visual acuities, 612 or less, then they're not going to notice the nuances in the change by using the default as opposed to the specified correct ones. Patient will reject the lenses. Well, in some cases they will. The patient will complain. Well, if the patient rejects the lenses, yes, they will complain. So I just want to take a moment just to recap what we've been saying here. And what we're basically saying is that we need to take the measurements that we all know and measurements that we do frequently, but we need to take them in a way that we take into account the actual stance or the posture of the patient. We need to make sure that we tell the patient clearly where we want them to look, whether we want them to look to the right or to the left or up or down, bring your chin up, bring your chin down. And we just need to make sure we're communicating effectively with the patient through this. So I'm just going to pop the slides off now so that I can see everybody and everybody can see me. And what I'd just like to do is just sort of demonstrate on the specs that I'm wearing at the moment how the position of the frame will affect the measurements that you're taking. So if you've got the frame tilted too much, then first of all, we're going to have an effect where it's touching on the cheek. As it touches on the cheek, you lose some of the air circulation. As you lose some of the air circulation, then the patient can find that it's a little bit uncomfortable because we're not refreshing the air around the eyes. But then we've got the lens tilted. Now this is a lens that's tilting along the horizontal, and that means it's going to induce a horizontal sill. Now, I'm going to try not to break my specs, but if I then twist it like this, I've now got a face form angle showing there that's at about 10 degrees instead of what I normally wear it at, which is 5. And as I tilt it that way, then tilting it that way, I'm twisting it around the vertical. So that is going to give me a vertical induced sill. So if I've got that one and that one both wrong, then we are going to adversely affect the prescription by more than we normally would do by just having one of them wrong. Now, I'm just now able to see into the chat. Oh, and it's David doing a chat check. Thank you, David. But I do have a hand up, and I'm not sure who it is that's got a hand up. Do we have a question from the floor? If you'd like to just unmute your microphone and ask the question, or if you'd like to type into the chat, I can try and answer for you.
I think that's unmuted now, Lim.
Thank you.
It was Zamina Navki.
Thank you. Zamina, could you give us your question? If you're talking, I can't hear you.
Sorry, it was an accident.
Oh, not
okay.
a problem. Not a problem. I've done that on many an occasion in these Teams meetings, and people, is that the same hand you had before, Liam? Oh no, yes, sorry about that. Thank you ever so much though for clarifying that for us. So just to finish off, I've got about 5 minutes left according to my stopwatch in front of me. These measurements, please don't think I'm sitting here saying you don't know how to do them. This is how you do them. This is very much more a case of it's a reminder and just one or two little tips that I wanted to give. Now I can see Simon's got his hand up. Simon, do you want to jump in?
You can correct me on this. I've been doing this for a long time now, and I don't do many aspheric lenses, even for high prescription, because I find that certainly patients who fall and patients with certain head postures and things, if I give them aspherics, the periphery of their lens, and they generally don't, our patients generally don't move their necks as much. They generally move their eyes around more because they might have arthritis in their neck, or they're sat in a certain position where they don't move their neck as much as we do. So if you give them aspheric, I find they generally, when you go back next year, they've either already changed them, or you get back and they say, I'm not happy with these lenses. They're not as good. So for higher prescriptions, I still generally just do a higher index and less aspherics than I would if I was working in practice. Is that wrong? Is that is there any benefit of doing aspherics for our patients, or is it better to do a higher index spherical?
One of the things I find, Simon, is that, and I think I might have alluded to this earlier, if it's not broken, don't try and fix it. So if the patient is happy with the design of lens that they've got, then stick with it, because we're just inviting problems otherwise. One of the things that we often can do is remember that if we are doing an aspheric, for every 2 degrees of tilt we have, pantoscopic tilt, we need to drop the optical center by 1 mil. So if we've normally got a 10-degree tilt on the frame, then we would drop the optical centers by about 5 mil. And that can reduce some of the swimming effect that the patients have. However, I am a big fan of using a higher refractive index with a shallow base curve, which then takes away some of the necessity of the aspheric to thin the lens down. So if you can get the base curve, the back curve, as flat as possible, using the highest index that you feel appropriate, then that is as effective as an aspheric lens. But you know, it's all a case of making that clinical judgment. Is the patient having neck, head, shoulder mobility issues? If they do, then I'm much more likely to stay with a full aperture lens as opposed to an aspheric. Sorry, that might have been a bit long-winded there, Simon, but I hope I've made that as clear as mud. Yeah,
that's good. I've got another question as well, because obviously dispensing is something that not a lot of us is our favourite subject, shall we say? But on a patient with low vision, so people who are sort of N10, N12 sort of thing, am I right in saying if we give them a thicker lens, they get more magnification?
Absolutely. Now, when we think about spectacle magnification as a profession, we normally think about the spectacle power and the ocular refraction, and the difference that we find there will help us do the spectacle magnification, and we forget that in reality we've got thick lenses. So there's two parts to spectacle magnification. The first is what we call the power factor, which is dependent on the vertex distance and the spectacle prescription. But then we've got the shape factor, which is dependent on the front curve power, the refractive index, and the center thickness. And particularly with positive lenses, we can manipulate the shape factor quite successfully to increase the spectacle magnification. By using a lower refractive index and a thicker lens, we can get more magnification. And what I used to do in one of my previous roles, I was a low vision practitioner at a hospital in King's Lynn. And I often used to put patients into standard plastics lenses and have a fairly steep front curve in order to give them more magnification. I never put them in high index, I never thinned it down, and I never used a flat lens, because as you quite rightly said, by using a steeper lens, a thicker lens, we can increase the spectacle magnification, sometimes by as much as 10%, which might just be enough to give the patient that little bit more comfort when reading or whatever. So yeah, the thickness and the front curve can make a huge difference to spectacle mag there.
Thank you. And for example, if we had someone who'd been prescribed, say 1.67 previously, because they had up, if they were high index, they're +3 with a +4 add, and so they've been used to a lightweight lens. Is it a good idea to drop them all the way down to a CR39, or would you drop them down to a 1.6 so they've got the balance of magnification and weight?
That's a great question. I could fall out with you, Simon, making me go back into my memory this way. So if we look at a 1.67, the specific gravity of that is 1.34. The specific gravity of CR39 is 1.32. So we shouldn't get a huge difference in weight there for the patient. So I think you mentioned a +3 with a +4 add, so we're looking about a +7. I think I'd be tempted in the first instance to try the standard CR39 and see how the patient got on with it, because I think the patient would find that the benefit optically outweighed the small increase in weight due to the extra thickness. I have seen people that step it, so they go 167, then 16, and then at the next one 1498. But I'm a firm believer in just trying the whole thing in one go and seeing if that works. If not, then step back and go to the 1.6. Again, it's about communication though. If you say to the patient, look, we're going to try this thicker lens for you, might be a little bit heavier, but it should be able to make you see that little bit better. It's not going to be magnificent, can't turn the clock back, can't put you back to 21-year-old sight, but it might make an increase for you. I often find that patients are happy to try something like that with the knowledge that we can change it if it doesn't work.
Thank you.
So everybody should be able to unmute themselves if they have a question. So we've turned the microphone option on. So has anybody else got any further questions? I think I'll take that as probably not.
People are just grateful that it's tonight and not last night, so they could watch the semi-final of the football last night and do CPD tonight.
Fair enough, fair enough. Last call for questions, everybody. Anybody got any further questions? Okay. So, well, thank you very much, Liam. Fantastic insight and content as always. And this concludes the webinar series for this year. However, next year we already have a roadshow and webinar schedule confirmed, with events starting in March. So March the 5th, we're in Glasgow at the Alona Hotel. May the 21st in Brick House Holiday Inn. July 9th, Birmingham NEC. Reading on the September the 17th, and Brentwood on November the 19th, with webinars running through March, June, October and December, with topics such as fields, low vision, communication and neuro-ophthalmology to be discussed. So all details will be sent out along with the CPD certificates. So if you can make it along to any of the roadshows, that we would be delighted to see you there. And also the webinars will be there as well. And we look forward to seeing you there. So have a great Christmas, everybody, and Happy New Year. And as I said before, the CPD certificates will be sent out to you within 7 working days of today. Thank you for attending, and have a great evening.
Can I just say thank you very much to David, who's organised all our CPD all year, done a brilliant job of providing us with great speakers, not only Liam, but the speakers all throughout the webinars and the road shows. They've all been fantastic, and we've got very good feedback from you. And so we look forward to seeing you next year, and have a good Christmas.
Thank you very much, Simon. Take care, everybody.